Welcome to the fifth meeting of the Interim Joint Committee on Health and Family Services, Health, Welfare, and Family Services. And we do have a full agenda, as always, so I just want to thank the folks who are here in the audience and everyone watching and listening on Zoom. Just a reminder to any members who are participating remotely, everyone should be muted unless you are actively speaking in the meeting. And please use the chat feature to notify staff if you want to be recognized for a question or a comment. When you are answering the attendance roll, please indicate or if you are in your LRC office or home office. Thanks very much. We'll go ahead and call the meeting to order. And Secretary, if you are ready, please take the roll.
Senator Rocky Adams. Senator Berg.
Present from my home office.
Thank you. Senator Danny Carroll.
Present remotely from my district.
Thank you. Senator Gibbons.
Present in the committee room.
Thank you. Senator Harper Angel.
Present remotely in the district.
Thank you. Senator Howell. Senator Kerr.
Present in Lexington.
Thank you. Senator Meredith. Thank you. Senator Nemes.
Present in the room.
Thank you. Senator Wise. Representative Bentley.
Present remotely from my district courthouse.
Thank you. Representative Bowling.
Present in the room.
Thank you. Representative Bray.
Present in my district.
Thank you. Representative Birch. Thank you. Representative Dotson.
Present in the room.
Thank you. Representative Elliott. Representative Fleming.
Present in the room.
Thank you. Representative Frazier.
Present in the room.
Representative Marzian.
Present in the 34th district.
Thank you. Representative Prunty.
Present in the room.
Thank you. Representative Rayburn.
Present in the district.
Thank you. Representative Raymond.
Present from my district.
Thank you. Representative Riley.
Present from my district.
Thank you. Representative Sharp.
Present in the room.
Thank you. Representative Sheldon.
Present in the room.
Thank you. Representative Tate.
Present from my district.
Thank you. Representative Weber.
Present in the room.
Thank you. Representative Westrom. Representative Wilner.
Present in the 35th House District.
Thank you. Chairman Alvarado.
Present in the room.
Chairman Mosier.
Present in the room. Okay, thank you. We do have a quorum established to do business. And the first thing that we need to do is approve the minutes from the August 26th and the September 2nd meetings. Hopefully all members have had a chance to review those. Are there any questions? All right, I'll entertain a motion to approve. We have a motion and a second. All in favor?
Aye.
Any
Aye.
opposed? Okay, thank you. Any opposed? All right. We have approved the minutes, and the first item on our agenda today is I wanted to take a look at the statewide vaccination rate for COVID and really kind of see where we are, how we're doing, and talk a little bit about hospital capacity, and also discuss as part of this conversation, I think we'll go from one transition fairly easily to the other, talk about the hospital shortage. So first I'd like to invite Nancy Galvani, Jim Musser, and online we should have Dr. Irfan Boudani with us to discuss the vaccination rates. And actually if, I'm not sure if the cabinet is online yet, but if they have anything to add in this respect, that would be welcome as well. Please introduce yourself for the record and please proceed.
Certainly. Thanks. I'm Nancy Galvani, President of Kentucky Hospital Association.
I'm Jim Musser. I'm the Vice President for Policy and Government Relations for the Kentucky Hospital Association.
Thank you.
And remotely, I'm Irfan Boudani. I'm pulmonary critical care. I practice in Northern Kentucky.
Thank you for being with us. All right. go ahead.
All
Thank
right.
you.
Well, thank you, Chairwoman Mosier and Chairman Alvarado. We appreciate the opportunity to be back here today to talk about these subjects. Very, very important concerns, particularly the staffing issues with our hospitals. So I am going to hit vaccination capacity and staffing while I'm here. So as we reported to you earlier this month, Kentucky's facing an unprecedented surge in COVID-19 cases in the hospital due to the Delta variant. And because the number of COVID-19 hospitalizations is so high, it's actually well exceeded the highest number that we had earlier in the pandemic. As of last week, and the numbers move around a lot, the number of hospitalized individuals with COVID-19 was over 2,500 people. Our hospitals have responded to this increase in demand by adding over 200 additional ICU beds just within the last 3 weeks to meet this increased demand. And yet, even after doing that, there was fewer open ICU beds available because the beds were being filled as fast as we could create them. Even with more than 200 beds added, the demand has been so great that there were fewer ICU beds available yesterday compared to August 24th, several weeks ago. A mere 7% of ICU beds were available across the state as of last week, and I'm sad to say that was the case as of yesterday. As we talk to our members, some hospitals have begun just late last week to see a very slight decline in the number of COVID-19 patients. Unfortunately, all of those same hospitals report they are seeing even higher ICU use for COVID patients, and that most of the COVID patients are on ventilators in the ICU. So while we might soon be approaching a plateau, that shouldn't be taken that we are coming out of the woods. We learned last week that the supply of monoclonal antibody therapy, that's Regeneron, is now being federally allocated to states, meaning that Kentucky might get a lower supply at the exact time that our hospitals are ramping up in their ability to provide this therapy to treat more patients. Last week, as we talked to our hospitals, most said that they were running out of the supply they had, and they were going to have to cancel appointments. If fewer patients can receive this treatment, it could cause the number of hospitalizations to go up. Sadly, this isn't the beginning of the end, but to paraphrase Churchill, it might be the end of the beginning of the current surge. Hospital beds across the state are full or nearly full. As of yesterday, and a lot of you get, I believe, our COVID dashboard that just came out today. We put that out every Wednesday. There were only 110 open and staffed ICU beds all across the state. 59% of our hospitals with ICU beds said they had 0 open beds. The crisis continues to be primarily among the unvaccinated. Approximately 58% of the population of Kentucky is fully vaccinated. Statewide, over 92% of hospital admissions for COVID-19 since March are among unvaccinated individuals. It's consistent across the Commonwealth in all of our hospitals, large, small, rural, urban. About 95% of the COVID patients in ICU are unvaccinated. All of this means that there are fewer open beds, and particularly ICU beds, to meet the needs of other patients that have medical need for that care. Cancer patients need that care. Cancer cases haven't gone away. Automobile accidents haven't stopped. Heart attacks haven't stopped. Strokes, you can go on and on just because we have the pandemic. But because of this pandemic, our hospitals have less capacity to treat these other illnesses. About half of Kentucky hospitals have added the COVID vaccine to their existing vaccine policies, which are required for employment. Many required their employees to have their first vaccine by September 15th or file for a medical or religious exception. In talking with our members, they report the overwhelming majority of staff are receiving the vaccine, and there has been no operational impact from adding this requirement. Also, as you probably know, President Biden has now announced that all healthcare facilities in the United States that receive Medicare and Medicaid funding, which of course is all of our Kentucky hospitals, will be required to have their staff vaccinated. We expect CMS to issue an interim final rule with this requirement within the next few weeks. Fully vaccinated staff are available at the bedside to care for patients. Unvaccinated staff are not always available to tend to patients because oftentimes these staff have to be in isolation or quarantine due to an exposure or testing positive for COVID. We talk to hospitals every week all across the state, and many are reporting a huge number of their staff that are off in quarantine or isolation. Last month, KHA, KMA, and KNA joined together to issue a joint statement in support of the vaccine for healthcare workers. KHA, KMA, and the Foundation for Healthy Kentucky are partnering on creating PSAs to encourage Kentuckians to get vaccinated. The number one concern for all Kentucky hospitals that we hear over and over again is staffing. As we reported earlier this month, the number of staff beds has begun to diverge significantly from the number of licensed beds, and that's because of staffing. Hospitals are facing a shortage of nurses and other qualified staff, and that limits the number of patients that hospitals can serve. There are more than 150,000 open nursing positions nationwide and several thousand open positions in Kentucky. We want to be clear, however, that the staffing shortages are not new. They've been growing for some time. COVID-19 has simply sped up the problem and shone a very bright spotlight on it. Kentucky, like the rest of the country, is facing a demographic black swan in healthcare. Baby boomers have begun retiring in large numbers, and that includes healthcare. Fewer nurses and other qualified healthcare professionals are coming through the educational pipeline, and that means not enough new workers to replace the ones that are retiring. The demand is driving up the cost for staffing. Our hospitals are paying significantly more for staff, both to retain their current staff and to bring in agency nurses to help fill some of the gaps. Hospitals have increased the hourly rates for their staff, plus they're paying retention bonuses. Plus, they're paying bonuses for their current staff to work additional shifts. COVID patients are extremely sick. Our staff are exhausted. And even the offer of additional money often is not enough for our staff to agree to work additional hours. As we have previously stated, Kentucky hospitals are in competition with other states, not just within our state, but all across the country, for a limited number of traveling nurses. According to a recent study by Qualivis, and that's a national staffing company, the market rate for traveling nurses has increased from about $160 an hour in July to now over $200 in September. As you may recall, Kentucky's reimbursement from Medicare is one of the lowest in the country. This puts our hospitals at a distinct disadvantage because we're competing with other wealthier states, New York, California, Texas, Florida, many others, to bring in these traveling nurses to help fill the gaps. It's not a competition within our state, it's a national competition. Keep in mind that the traveling nurses are able to command pay rates between $160 and $200 an hour. Kentucky has to compete in a marketplace that does not reward poverty or low reimbursement. Our hospitals tell me that they cannot sustain the amounts they're having to pay for staffing. In 2020, Kentucky hospitals lost $2.6 billion due to COVID from lost revenue and additional costs. $1 billion of that amount was not covered by the federal provider relief funds from the CARES Act. There have been no more federal relief payments to the hospitals, despite the ongoing costs related to this surge. There are several things that the General Assembly can do to help our hospitals in this time of crisis. First, we continue to ask that you vocally support your local healthcare heroes who, despite exhaustion, frustration, and at times despair, continue to serve our patients. We would ask that you support an appropriation to help hospitals retain our current staff and recruit additional staff to make sure that we can serve our patients, your constituents. As helpful as an appropriation would be, it will not be a panacea, but it would provide needed immediate relief to enable our hospitals to expand their frontline staff and to relieve the strain on capacity and care at the bedside. As we previously reported, Arkansas has already provided help to their hospitals from the state's federal ARPA funds, which are intended to be used to help with the cost of staffing in hospitals and other healthcare facilities. Arkansas has now been joined by other states, including Mississippi, Arizona, Alabama, Texas, Michigan, and Kansas, just to name a few. We appeal to you for similar support. Such funding would provide much-needed short-term relief to stabilize our hospitals by helping them to supplement some of these extraordinary staffing costs. Looking at a post-pandemic world, which we hope we can get back to, our healthcare system will continue to face the growing demographic problem, and the question becomes how to address it. KHA is establishing a new workforce committee, which will be looking at ways to improve the numbers of new healthcare workers coming through the educational system. We'll be looking at issues in addition to just the supply, but including workplace violence, burnout, and resilience. We've begun reaching out to seek new partnerships with those in higher education, such as the leadership at KCTCS. Kentucky's excellent community and technical college system already produces many of our fine nurses, but we think we can work together for even more qualified staff. We also intend to reach out to Kentucky's four-year institutions because there's opportunities there as well. Our hospitals have been examining how to encourage high school students to pursue a career in healthcare. Our plan is to work with the KMA and the KNA and with other organizations to confront our common challenges. We've been reaching out to our federal delegation also for information and assistance in finding ways to make it easier to retain and attract qualified healthcare workers. We will be reaching out to you and the Cabinet to address challenges and barriers that might exist in our current laws and regulations, which could be changed to help improve the number of new healthcare professionals in our state. The future of our patients, your constituents, and of all of our people depends on us working together, and we stand ready to do our part at KHA. And I'm happy to take any questions.
All right, thank you so much. That was a lot of information and, a lot of really valuable information. I think that we all needed kind of an update. When you're looking at the vaccination rate in Kentucky, are you taking the percent of the total population, or are you deriving that number from the eligible population? I've read two things, and I don't know if nationally we're looking at total.
I think it's the total population.
Yeah, I think it is total too, because I read something recently that talked more about eligible population, and those of course would be individuals 12 years and older, and we were closer to 70 to 71% of our eligible population who had at least received at least one vaccination. So I thought that was positive. So, but it is kind of a slow process, and I certainly appreciate your efforts and the efforts of so many other healthcare organizations who are putting out public service announcements and really trying to get accurate information out. I think what I'll do right now, we do have a couple of questions. I guess I'll go ahead and ask Senator Berg to ask your question. Are you online, Senator Berg?
I am. Thank you. Thank you for a very, very informative and actually concise presentation. There was just one piece of information that I had received that I wanted to share with the group. U of L put out an email earlier this week that there, and I forget honestly if the number was 12,000 or 16,000 employees, only 5 have refused to get vaccinated. Everybody else said yes. And I thought that was extremely positive news. Everybody's so concerned about healthcare workers leaving with a vaccine mandate, and their experience was not the same. So I just wanted to share that with the group. Thank you.
Okay, thank you, Senator Berg. I think at this point, just to allow Dr. Boudani to present, and I know that you have to get back to work, what I'll do is I'll let Dr. Boudani give us some information about what I wanted to know from you, Dr. Boudani, and we had this conversation in the hospital last week or a week and a half ago. Kind of, who are you seeing in the hospital? Who are these patients? What are their ages? What are you seeing on the ground? And talk a little bit about what you hear from your colleagues in terms of burnout. I know that this has been a really difficult almost 2 years now. And if we could just really kind of get a picture of who these patients are and what's going on the ground, if you can fill us in, that'd be great.
Thank you very much. I appreciate the invitation to come and talk to you. And, we've been at this for 18 months almost. And things have changed in the last 18 months. The kind of patients we're seeing have changed. We've had multiple spikes in the last 18 months, and it has seemed, at least to us who are on the front lines looking after these ICU patients, that every subsequent spike has been worse than the previous one. And with the latest Delta spike, our patients are much younger, much sicker than any of the previous spikes that we've had. And the majority of this, as previously mentioned, is being driven by unvaccinated individuals. And I would like to add that this disease is a preventable illness. We have tons of now healthy, young, productive Kentuckians who are now dying of a preventable illness, disease that is completely preventable, or at least to a large extent, by wearing a mask and getting the vaccine. We have good efficacy for the vaccine, and there's multiple data published out there. But we are seeing younger, sicker patients. We are having difficulty transferring patients for tertiary level care. For example, we had a young 38-year-old pastor who was very sick a couple of weeks ago, had refused to get vaccinated. The whole family got sick, including some of his older relatives. Everyone else did well except him. He was the youngest and healthiest, and he got deathly ill. And the family's question was, we thought he would do fine. Why is he the sickest? And the answer is, we don't know, right? But that question would not have come up if the vaccine had been taken. But anyway, he was sick enough. He ended up requiring what is known as veno-venous extracorporeal membrane oxygenation, which is a bypass. And we initiated that at our institution, and then were looking for a tertiary care institution to take this patient. And we could not find an open bed for VV ECMO in entire of Ohio, including OSU, Cincinnati, University of Kentucky, University of Louisville, Vanderbilt. We called Atlanta. All the Atlanta system areas were full. We called University of Chicago. Everyone was full, and we had to keep the patient, and we were able to get him through it, and he's doing better now. But that's the degree of desperation sometimes you face with these critically ill young patients who you're trying to save, but your resources are getting stretched thin. So we've also, of course, dealt with this face-to-face, where we see the desperation in your patients' faces when you're about to put them on a breathing machine. And a lot of times they express regret, about not getting the vaccine, or not wearing a mask, or going to their, family outing with other people. And a lot of times, it's too late by then. Say we are ready to take the vaccine now, but it's too late. So I would like to emphasize this is a preventable illness, and I appreciate everything that is being done from everyone about trying to put forth the message that there is ways to prevent this. The patients are younger, they're getting sicker, and even though there has been a plateau, the numbers are still very high. Resources are extremely stretched thin, and everyone is working as hard as they can. But there is going to be a point when resources may not be adequate, as in the case of VV ECMO, where we could not find a bed across multiple states for this patient, and we had to keep the patient here and manage him here. So that is my input. If there's any other questions you have, I'd be willing to answer them.
Thank you so much. I really appreciate your being here. I know that you're busy taking care of patients, so pulling you away is certainly a big ask. So, but we do have a couple of questions. I'm going to ask Co-Chair Alvarado to ask his question first, please.
Thank you, Madam Chair. Dr. Budani, thank you. I think for I know when we use the term ECMO in healthcare, we as physicians, we know what that means. When we talk about extracorporeal membrane oxygenation, it's a fancy term, but for members of the committee and for those who are watching, what that basically means is you put a tube into someone's venous system, you take the blood out, you oxygenate it outside the body, and then you pump it back in because the lungs are so damaged or so diseased that they cannot allow oxygen to be transmitted through the vessels there into your bloodstream like we would normally do when we take a breath. It's so plugged up, so damaged that you can't do it, that you've got to have a fancy machine to do that. We often do it for babies with cardiac problems, and obviously in adults that are, that we think have a chance to survive. So maybe Dr. Budani, you could talk about, I'd like to know from your perspective as a doctor, obviously and a pulmonologist, what's the strain like? What are you observing in the hospitals from our healthcare workers, from our nurses, from our doctors? How much toll is this taking on them right now?
So I appreciate your question. Thank you very much. And it is taking quite a bit of a toll. People, like I said, have been at this for 18 months and counting, and people are getting burnt out. We have, healthcare providers that are thinking about switching careers, healthcare providers that are thinking about retiring, healthcare providers that are going into completely non-health related fields because the pressure and the stress of the last few years has been extreme. I know a lot of my colleagues have PTSD. To be honest, you go to bed at night and you can still hear the ventilator alarms and the pump alarms going off in your head. So it is, but this is the oath we swore, and this is what we do, and we will do it to the best of our ability for as long as we can. But we appreciate, and we would also like to emphasize, at least I would, from my standpoint, as speaking as an individual, is more emphasis on the fact that this is a preventable illness, and majority of these deaths that we are seeing are preventable, and that is the bigger frustration. For healthcare workers, I think, at least in my experience, is we get these young, sick patients who are not doing well, and the disease is such that beyond a certain point, we sort of can anticipate what the outcome will be. And no matter what interventions you do, the outcome remains unchanged. And it becomes very frustrating that, not like other diseases where you have some degree of control over the outcome. You can do additional interventions to change trajectory of patients. In this illness, at least with the Delta strain, it doesn't seem to work that way. There's some patients who will get better, some patients who will get worse no matter what you do. And there's no rhyme or reason sometimes as to why that happens. This virus, this strain is extremely transmissible. According to some literature, the viral loads in the nares are 1,000-fold higher than the wild type, which was the original, COVID strains. And because of that, it is rapidly transmitted. It multiplies very fast, and it can overwhelm even normal immunity, which is the issue, because it's so virulent, multiplies so fast that even young, healthy patients who previously were not the people we were seeing in the ICUs, but now we are seeing them because even those people, if they get a high enough inoculum, are getting overwhelmed by this virus. And every time, to be honest, I go out, in public, and I see, people outside not wearing a mask and, enjoying their everyday lives. I feel, that's their right, but it also makes me concerned because I don't see how there will be an end to this if we don't get enough vaccines, or we don't put out the message that you need to mask up to control this. But that is my personal opinion.
If I could, one other question, Dr. Budani. I think a topic that's important from a specialist like yourself to address. I know there's a lot of folks out there who think there's somehow curative treatments for COVID, and I remind people that we don't have cures for the common cold. This is a virus. We try to do things to help support the body as it develops kind of a response or a reaction. There are a lot of people out there who are pushing for some of the treatments that we see of things like hydroxychloroquine, ivermectin, people that are proposing legislation to allow outside physicians to come in and dictate to a hospital to allow people to take that. Maybe you could, I don't know if you've had a chance to review the literature, review studies, if you could maybe address that topic briefly for those who are considering those. People seem to think that that somehow is going to fix problems for this. If you've either seen people that have taken it, if you know people that have prescribed it, if you could perhaps address that issue.
So in my personal opinion, having reviewed all the data that is out there to the best of my ability, there is no cure for this virus. You have therapies that will attenuate the immune response, and allow the virus to be cleared by the immune system. Medications that modulate the immune response include the steroids and some monoclonal antibodies, including the Regeneron or tocilizumab, which is a medication that is an antibody that affects some of the inflammatory markers, the interleukin-6 specifically. But those are the best bets out there. And then you try and prevent secondary injury in patients who are really sick. You give them medication to modulate the immune system, and then you prevent secondary injury. You prevent fluid overload. You prevent renal failure. You prevent secondary infections, and you provide supportive care. You prevent blood clots. If they end up on a ventilator, you try and provide the best ventilator therapy there is to prevent secondary injury. That is the best we have out there. There is no medication in peer-reviewed literature that shows that it is effective as a cure for this disease. There was a meta-analysis that was published about one of these medications in the recent past. It had to be withdrawn because some of the databases that were included in reaching those conclusions were either found to be defective or erroneous. So as far as I know, there is no peer-reviewed literature that shows any medication works as a cure for the disease. And and that is the issue. In my opinion, we should listen to the science, listen to the experts. We have people who have dedicated their lives studying infectious disease, viral illnesses, people at the CDC, the NIH, the FDA. These are the experts, and we should trust the science. It's kept us out of trouble this long, and we should trust the science and listen to the scientists who spend their lives doing this. And if they say we should follow certain therapies and follow certain procedures to reduce the death toll and reduce the pandemic burden, then that's what we should do, in my opinion.
Thank you, Dr. Budani. I appreciate that. And I think some of us have argued that perhaps if we had allowed our medical professionals to take the lead on the messaging from the beginning in our own state, we probably would have had a better response and not quite of a political nature. I know I've argued that. And we need individuals like yourself to be able to, people frontline who are treating this every day, to be able to convey that message. For our members from the KHA, I got a couple of questions for you as well. I know you've talked that obviously the nursing shortage, not only just nurses, aides, respiratory therapists, critical care physicians. You hear from our doctor here today. A lot of people looking at changing careers. This has been going on a long time. There's a lot of factors, and I can spend an hour going through all those factors. But you've mentioned this has been going on for a while. We know a lot of other states: South Dakota, Georgia, Arizona, Arkansas, Texas, Missouri, West Virginia. Just I think passed something 2 days ago to help with this problem. We had a special session. I made a plea to the governor to be able to see if he can do something, either to allocate more funds to be able to help with this problem immediately right now. This has been going on for a while. Did you all convey this message to the executive branch and to the governor in the past year as far as this? Because a lot of other states have already taken action from a year ago. Was this conveyed to the cabinet, to the governor's office in the past year?
Yes. So prior to the special session, I think we sent a recommendation to the House and the Senate leadership, as well as to the administration, a proposal modeled very similar to the Arkansas plan. And so, yes, we have made that request. And that is the number one thing as I talk to hospitals all across the state is staffing. And they just tell me that, the astronomical amounts that they're paying, it is just not sustainable. And so any assistance is appreciated.
What would you say to the arguments by members of the cabinet and leadership who say that you already have been allocated enough funds to handle this problem? What would be your response to that?
Well, as I've mentioned, we haven't received any additional federal provider relief funds. And the data through just 2020, we had $1 billion of losses that weren't covered by those funds. There haven't been any more federal funds provided to us. We certainly appreciate this legislature passing our ATRIP legislation, but that was money. Of course, the hospitals put up the provider tax to draw that money down, and that was for Medicaid. But that has helped. But that program ended, and we're still waiting for CMS to approve that continuation. So that was not money for this. It has helped the hospitals, but I think we felt like we'd be coming out of this earlier. But this is dragged on. And I think what you heard from the physician is, it might be plateauing, but it's not going up and coming back down. It is still very high. Resources are strained, and hospitals, large and small hospitals, are all saying that they need help.
What about the reports that there's hospitals having to borrow money to be able to maintain payroll? Is that accurate?
Hospitals have had to borrow money to retain their current staff and to help pay for traveling staff. That is accurate.
Are there quite a few hospitals at risk of closing, particularly in rural communities right now, because of this?
There's always been a number of hospitals that are in poor financial assistance, and there's financial help. There's lots of studies out there. Anywhere from 18 to 26 hospitals were in poor financial condition before this hit. So it's hard to say. I think we're concerned about that long term.
So I know I can go, like I said, too long. I talk too long as it is, Madam Chair. I appreciate the indulgence. I'm going to make one plea to the camera, and hopefully Governor Beshear is watching, because I know Governor Beshear likes to communicate through television. And so sometimes when we try to make phone calls, there's not a response, or when letters, there's not a response. So Governor, if you're watching, I made the plea during special session. I'm making it to you again. This group stands ready to act on this issue. If you need a formal letter from me, but if you want to hear it directly through cameras, because I know that's how we like to communicate, I'm asking you now to call us into special session to handle this issue before we start losing all of our staff, because this isn't the last surge for COVID-19. Another surge is going to be coming in the future. And if we don't have staff that are burned out or have left or have gone to neighboring states because they're getting paid more, we're going to be stuck holding the bag in the future, particularly if these vaccines that we're getting now don't hold true for future surges. So I would ask you, Governor, please call us in and allow us as a General Assembly to use ARPA funds to fix this problem. If the concern is that there's not funds there, we can redesignate those from other projects towards something that's facing us right now. And the longer we wait, the worse this problem is going to get. Thank you, Madam Chair.
Thank you. I appreciate all of your sentiments, Senator Alvarado, and thank you very much for this great presentation. We do have a lot of questions, both for you and for Dr. Boudani, I believe. I just want to quickly say, Dr. Boudani, you talked a little bit about ECMO, and I just want the folks here to understand the seriousness of that procedure. That is a labor-intensive procedure. I was on the ECMO team for Children's Hospital in a neonatal intensive care unit years ago, and it took 2 nurses and at least 1 physician at the bedside constantly with this patient. And I think another really good point to bring up are, while we're talking about the cost of all this and the cost to the hospitals and the cost to really all of us when we're talking about healthcare costs, are, the cost of a vaccination is about $40. The cost of monoclonal antibodies is probably in the ballpark of $2,400. And this is, if we all had to pay for this. So, Dr. Boudani, do you have any idea, or perhaps Nancy, the cost of ECMO or the cost of a typical intensive care unit stay? I know it's really variable.
It is.
So as far as I know, that the ECMO code, CMS reimburses the hospital for the DRG code in the realm of about $150,000 for the DRG code. But I'm sure there's going to be additional money based on the other services that are required. So yes, you're right. Prevention is much better than cure. It's much cheaper as well.
Right.
And this is the most intensive therapy that can be offered by any hospital, any ICU. So this is the most aggressive, most intensive care you can provide the patient, and it is very expensive.
Right, and it depends on how long the patient is on ECMO, of course, and so forth, and that doesn't even include the rest of the hospital stay, like you said. So I'm going to go ahead and move on to questions because we do have a lot. Representative Dotson.
Thank you, Madam Chair. And I want to thank you guys for the presentation. Great information today, by the way. But I was wanting to ask Dr. Boudani, do we have a recovery rate between the vaccinated and the unvaccinated?
So from our experience, patients who end up in the ICU critically ill, about 90% or more of those are unvaccinated, right? The vaccinated is single-digit numbers. And Those vaccinated patients are usually patients who have multiple other comorbid conditions like cancer, severe lung disease, renal failure, and other such issues who end up with COVID. And in my experience, I have no data, but in my experience, even those patients with multiple comorbid conditions who end up in the ICU with COVID, they seem to be faring better than the young, healthy ones who are unvaccinated. So in my experience, if you are vaccinated, you are very much less likely to end up in the ICU, which is where my experience lies. And even when you do end up in the ICU, you tend to fare better, even though you may have more comorbid conditions or more chronic diseases that would otherwise have made you a worse candidate for survival.
Right. The reason I ask that is because I've seen numbers nationally that the recovery rate is relatively close on both vaccinated and unvaccinated. I just wanted clarity on that. But I had COVID back in April, and so out of curiosity, I went and took the antibody test, the monoclonal antibody test. It tested very high, and talking with the pharmacist that done the test said that I'm in really good shape after having the COVID, and that really the level I had would rival the vaccination itself. Would it be possible if we could come up with something to where an antibody test from someone who's already had COVID and got monoclonal antibodies, would it suffice for a vaccine?
So, I'm not an expert in immunology, but immunity from vaccine is not dependent just on antibody levels, right? I mean, a lot of the immunity that you get from vaccines is dependent on what is known as the helper T cells, which are the lymphocytes that are sort of the quarterback for the immune system. So antibodies wane over time. Helper T cells last much longer. Helper T cells help accelerate and exponentially increase your immune response when you do get exposed to an antigen to which you are vaccinated against. When you get the COVID-19 has multiple antigens on it. The antibodies that you develop are against multiple antigens. So a good example is, you got attacked by a 300-pound bear, you used your buckshot and, you hit it in multiple places, you kill the bear, that's good. Vaccine is the opposite. Vaccine, you provide the spike protein antigen. All your antibodies are against that particular part of the spike protein antigen. You now have very high immune levels against that very important part of the virus. So all your immune effort and resources are now directed to the most critical part of that virus. So your chances, in my opinion, and just based on general logic, are much higher to fight off the Delta variant or a severe COVID infection if you were vaccinated, rather than if you had natural immunity. Antibodies are a surrogate marker for immunity, but they are not the best marker for how you would respond to a natural infection.
Right. And that question is really geared toward, for the employee shortage that we have, the healthcare workers. If they had had COVID and had high-level antibodies, would that suffice for them instead of taking the vaccine? So I just wanted to ask that question. Thank you, guys.
Thank you. Representative Fleming, do you have a question?
I do, Madam Chair, and thank you. I've got two quick comments. One, the ECMO procedure is it's an unbelievable therapy process, particularly when you have a very, very dear friend who went through that quite a few weeks. Unfortunately did not make it, but it's a good alternative to try to get the oxygen back into the system and so forth. So it's very, very tough, and I know it's very expensive, but that's sort of minor when it comes to trying to save somebody's life. I want to agree and back up and support the Chairman of Alvarado's comments on pleading to the governor. This is one of other departments that I'm just saying that's a total mismanagement and rather upsetting in terms of how things are handled. I have a question for Nancy and Jim, if you don't mind. One, you mentioned about the nurses being quarantined and so forth. Do you have like a test and stay procedure, or have they looked at that? It might have been mentioned in the past, but I don't recall it being mentioned in terms of having that type of approach.
So I think the guidance which we follow is the CDC guidance. If someone is tested positive, they have to be in isolation. If they're unvaccinated, they've been exposed, they have to be in quarantine for quite a while. And as we talk to our hospitals, there's lots of staff that are off because they're in one of those situations. I think if we were at crisis standards of care, you might be able to have people that are positive, if they don't have symptoms, come back and work, but I don't think we're at that level, and that is not recommended.
Okay, so it's basically if somebody's exposed, a nurse is exposed, then they would continue to get tested on a daily basis. If they don't show that they're positive, they still go into quarantine. That's what you're telling me. Is that right?
I believe if you're unvaccinated, you have to be in quarantine.
Right,
and after a certain period, you can have a negative test, but it's not right away.
Okay, I just want to make sure. The last one, I know a couple months ago we passed a bill that included paramedics. Is there any update on hospitals bringing on the paramedics in terms of supporting your
some
initiatives?
hospitals do employ paramedics, and they were very thankful to allow the paramedics to work elsewhere in the hospital. But, there's a shortage of paramedics as well. I mean, that certainly is helpful, and we were happy to have it, but it's just a small
part.
assistance.
Okay, thank you, Madam Chair.
Thank you. Representative Rayburn, do you have a question? Representative Rayburn, are you on? Okay, we'll come back to you if you jump back on. Representative Birch.
I have a couple of statements. One is, when all else fails, tell the truth. The second statement is, follow the science. We've sent out dual messages. Some of our politicians have done this here, called doctors even, sending out false information. My question is, what, as a hospital association, do you all recommend that we as politicians and the public should know the simple things that we should do in order not to prevent it, but to reduce it and keep other people from getting this virus? I've had 2 grandsons get it and got over it pretty fast. My daughter got it, took her 3 weeks, and she's still suffering from it. And my sister got it for 3 days and passed away. So I know what it's like to deal with this. And for people to run loose in this state and not do what is supposed to be doing and protect the public and protect ourselves and our families, they run loose not wearing their mask. They run loose not getting inoculated. And we sit here, and some people here, even on this committee, endorse what they do. I'd like to know what you all recommend, very simply, what we can do as politicians and what the people can do in order to lower the infection rate of this.
Certainly. Representative Birch.
Take your time.
We endorse the vaccine, and we have worked very hard for many months. In fact, when the vaccine came out, KHA on its own put out public service announcements encouraging people to get the vaccine. We've worked on 2 campaigns with Kentucky Medical Association, Kentucky Foundation for Healthy Kentucky, producing PSAs and, taking it out in all areas of the state, not just in Louisville, but in rural areas, highlighting folks and saying, why did they get the vaccine? So we are on a second campaign around that, but we believe strongly that vaccination is, what needs to happen. And, we are working to get that message out.
We have 6 counties in this state that are worst in the nation. And we just passed some laws this past special session that probably encouraged that to happen. Now, I know that you cannot suggest to people what they should be doing. Some things, we're at war. We're at war with this virus. People are dying. By the end of this year, there'll be more people die from this virus than died in the First and Second World War from casualties from action. So it's got to be a better way of getting people to do this here. When I went in the military, they stripped us down bare. We walked through a gauntlet and everybody got vaccinated. You didn't get a choice. You got vaccinated. It was for the common good. And that's what we got to do now. It's for the common good to do this if we're going to beat this. Thank you, Madam Chair.
Thank you. Representative Weber.
Thank you, Madam Chair. Nancy and Jim, thank you all for being here today. I think you've given us a lot of good information. I do have a couple of questions. I want to begin with this one. Have any staff at any of the hospitals or facilities that would fall under your jurisdiction been terminated from their employment for not getting a vaccination?
I believe there have been some, and I believe that's been in the news, where staff have made a decision not to comply with a requirement that hospitals have put in place to get a vaccine. Of course, that's their decision, and I think that has happened. Many of our hospitals, give warnings first, so they're following their existing policy of, you get a written warning, you get additional time, and again, all I can say is, in talking to our hospitals, most of the unvaccinated staff have gotten the vaccine. It's been a very low number that have had to be terminated because they have made that choice not to get it.
Okay, thank you. And one quick follow-up. So what would be the percentage then at this point, based on what you've said, of employees at hospital staff who have indicated that they are not going to get the vaccination or have not been vaccinated? What percentage level is that?
I don't have a percentage, but the hospitals tell me there has been no operational impact. It's been that low.
Okay. All right. Thank you, Madam.
Thank you. And Senator Meredith, do you have a question?
I do, Madam Chair. Thank you. And Nancy, I want to thank you for your testimony. You made a couple of points that I think probably need to be reinforced. One is that this is not a new issue. It's been there growing for over a decade. And COVID didn't cause it, but I describe it as it pushed it off the cliff. That's certainly where we are. And you also mentioned that if you are providing an appropriation, or hospitals are providing an appropriation from the governor, that this just buys time. It's not going to fix the problem. We need a long-term solution to it. And you specifically mentioned Arkansas. And I believe they committed $245 million to hospitals to help with retention and recruitment of staff. And Senator Alvarado's bill, which we were not able to hear, Senate Bill 8, I think we asked for $80 million, which is, I think, a paltry amount considering that our state is a third larger than Arkansas is, and this is a big problem. And if we are, in fact, at war, then we need the resources to fight this battle. We certainly need it. And I appreciate the governor sending the National Guard to some places throughout Kentucky. I don't think he's going to be sending them to Litchfield and Horse Cave and Hardinsburg, so we need those resources. But the question I have for you, obviously a lot of things have caused this. You may be interested to know that our state's kind of contributed this because, as you know, I'm co-chair of Government Contract Review, and I think we've approved at least a dozen contracts for locum tenens coverage for healthcare professionals for the state to meet its healthcare needs. So our state's been in competition with the rest of our state for these scarce resources, and they have, at this time, unlimited resources to do that, and that drives up the cost, and we don't have that. But how much has this problem been caused by our schools not being in session and the unavailability of child care? Because, again, I know this has changed over the years where it used to be predominantly a female workforce, but it's still a strongly female. It's just driving a lot of this.
I mean, it certainly plays a role. Certainly in the very first wave, that was a big problem when the schools were not open, because you're correct, a lot of the nurses had to stay home with their children, and that was a problem in the first wave. And so what I was hearing before the second wave hit was, people were very concerned about that. If the school shut down, well, number one, I was hearing before this wave hit that we hope another wave doesn't hit because we're going to be short-staffed. We barely have enough nurses to cover what we're doing. That's before Delta hit us. and then very concerned about if the school shut down, we don't know what we're going to do. So it's a contributing factor, along with a lot of other factors, exhaustion, nurses retiring, as we've heard healthcare professionals say, I'm done with healthcare, staff out on quarantine. It just, there's lots of factors that are impacting this.
Do you think the ask that we had, which is again approximately $80 million, is that sufficient? And do you have a number in mind if it's not?
Of course, we would love to have as much as Arkansas, but we appreciate whatever the legislature could do to assist us.
Well, again, I appreciate your testimony, and yes, we will beg our governor to try to address this issue. It can't be ignored any longer. But thank you, Madam Chair.
Thank you. Thank you all very much for your testimony. I know that you're probably going to be hanging around for the next presentation as well. Before I let you go, I just have a quick question. Are there other vaccines that hospitals require?
Yes.
What are those, and how long
The
have you?
most common, well, there's, I had a list before. I think they look at hepatitis, seasonal flu for sure, TB test. There's a number of different ones. Okay. There's a number of them.
I thought so. Okay. Thank you very much. All right. Dr. Budani, thank you so much for taking time out of your busy day and schedule to be with us. You are certainly welcome to hang on if you want to this very exciting committee and discussion. Actually, we do think that. And but I do thank you very much. Thanks for all the work that you do.
Thank you very much.
Of course. Thank you. Okay, next on the agenda, we have the official presentation on healthcare worker shortages. And with us, we have quite a few folks who can make your way to the table. And just, I'll let you introduce yourselves. We do have some folks who are online as well on Zoom to be part of this discussion. Corey, are you the only one here in person?
No, I think.
Okay.
I think we have
excellent. Oh, perfect. All right. If you all could just introduce yourselves, and we'll let the folks online do the same and proceed with your testimony.
Good afternoon. My name is Corey Meadows. I am Deputy Executive Vice President and Director of Advocacy for the Kentucky Medical Association.
Good afternoon. I'm Dr. Chris Williams. I serve as Chancellor for the Kentucky Community and Technical College System over academic and workforce development programs.
And good afternoon. I'm Kim Williams, and I work for KCTCS as the Executive Director of Applied Programs and Experiential Learning, and I oversee most of the healthcare curriculum committees.
Thank you.
Okay, thank you. I think online we might have a few folks.
Good
afternoon. Sorry.
Go right ahead.
Good afternoon. I'm Jacqueline Bitterman, Dean of Nursing at Jefferson Community and Technical College, a part of KCTCS system.
Thank you. And
I'm Donna Metter with the Kentucky Nurses Association, coming in through Zoom.
Okay, thank you. Well, welcome to everyone. Thank you for being here. And I know we talked a little bit in the last presentation about some of the short-term fixes and some of the problems that we're seeing in terms of attrition. And hopefully we're going to tap into some of those long-term solutions that we need to be thinking about. So thanks for being here.
Representative Moser, we appreciate the opportunity. I think each of us probably has a different focus that we'd like to bring, so perhaps you could start us off.
Sure, I'd be glad to. I want to thank the committee, and I want to thank you, Chair Moser and Co-Chair Alvarado, for allowing us to speak on this topic. Healthcare workforce shortages have plagued our state for many years. Such shortages have been exacerbated by COVID, or to quote Senator Meredith, COVID has pushed it off the cliff. And while there are immediate, acute needs in the short term, this is also a long-term chronic problem that calls for long-term solutions. Before we talk about some of the conversations that we're having, it's probably helpful to talk about how did we get here. And there are multiple reasons that things that have caused this shortage, but let me just talk about a few. lack of graduate medical education or GME funding. Generally, physician education is a two-step process that includes graduation from a medical school and then completion of a residency training program that can last from 3 to 9 years depending on the specialty. While medical schools have stepped up recently to increase the number of graduates, residency training slots have not increased, leaving hundreds of medical students across the country without a slot for residency training each year. Current federal law caps the number of federally funded residency training positions, freezing the number of available to that which it existed in 1996. Unfortunately, Congress has failed to respond for many years. I know there's some current efforts happening right now where they're trying to fix that problem. But because of the inaction, it has led to greater gaps between the number of physicians that we have versus the number of physicians that we need. There's also increasing patient demand. If you have called a physician's office and it takes days, weeks, or even months to be seen, you are experiencing firsthand the need for more physicians. So it stands to reason that this situation will become even more severe as our population grows, ages, and continues to suffer from poor health. And when you add a greater number of insured, which is a good thing, you still will have even more individuals seeking physicians. And it's not just our patient population that is getting older. Our physician population is getting older. Baby boomer physicians are starting to hang up their stethoscopes and move into retirement in greater numbers. You've heard it referenced, and I want to touch upon the physician burnout issue. With a majority of American physicians experiencing some sign of burnout, it is a condition that affects all specialties and all practice settings. Clearly, COVID has been a major source of such burnout recently, but these career fatigue or resiliency issues that we've talked about are years in the making. In addition to COVID, burnout is often associated with increasing administrative responsibility due to regulatory pressures and evolving payment and care delivery models. You hear us oftentimes talk about prior authorization and things like that. That's what we're talking about when we say administrative responsibilities and barriers. These types of things can lead to reduction in the amount of time that physicians spend delivering direct patient care. And when a physician is burned out, it can have a significant impact on organizational productivity, morale, cost, and the quality of care being delivered. There are also liability concerns. Tort reform, or the lack thereof here in Kentucky, is a major concern when trying to recruit new physicians. Physicians, like any other citizen, want a more predictable, fair process where the playing field is level for both sides. Legal cases can also drag on for years, and if you've ever been sued, and hopefully you haven't, but if you have, you know the emotional and financial toll they can have on an individual. Without reforms, we face an uphill battle recruiting and retaining the number of physicians we need in our state. Medical liability premiums also continue to be an enormous expense for physicians and the entire medical industry. You have to understand premiums differ by state, and it is a factor that can truly influence a physician's decision about where he or she locates their practice. And we know that medical liability insurance premiums have begun an upward trend after more or less holding steady after the past decade. And this is according to new analysis from the American Medical Association. In 2020, during the height of the COVID-19 pandemic, more than 30% of premiums reported on a Medical Liability Monitor national survey of liability insurers increased from the previous year, the highest percentage since 2005. The report also highlights Kentucky as one of 14 states that had 2020 premium increases of at least 10%. In fact, over 29% of Kentucky premiums were at least 10% or higher in 2019, and over half were up from 2019 by any amount. The largest premium increase was 24.3%. The AMA report underscores the need for tort reform in Kentucky. These are just a few examples of some of the root causes and the contributing factors to our shortages over the course of many years. But how bad is the shortage? Shortages impact every specialty. In fact, at a meeting of a severe mental illness task force, I think earlier this summer, we heard about the extreme shortage of psychiatrists for our state. But it's not just psychiatrists. The Association of American Medical Colleges states that Kentucky ranks 36 out of 50 states in terms of active physicians per 100,000 population. But some of the best data that we have focuses on primary care, which we all know is the foundation of our healthcare system. There's a white paper that was generated by Dr. Kevin Pierce and his team at the University of Kentucky a few years back, obviously pre-COVID, that analyzes the primary care workforce, simply looking at primary care physicians who include family medicine, internal medicine, pediatrics, and geriatric medicine physician. Kentucky ranks 43rd in the country for the number of primary care physicians per 100,000 population. According to the white paper, Kentucky produces and retains about 55 new primary care physicians per year and has to recruit 55 to 60 more from out of the state. With those two numbers combined, which is about 110 to 115, that is short of the 124 primary care physicians that the paper states that we should produce annually just to keep from worsening the shortage. To actually achieve the U.S. median within the next decade, we would have to add 246 primary care physicians per year. We are consistently falling behind. The KMA, along with other stakeholders, you heard from KHA, the Primary Care Association, and others, we've been talking and having this conversation for many years, but obviously, given where we are now, we've increased that dialogue. And we want to be offering to you concrete solutions on how to fix this problem. So I want to assure you those conversations are happening, they will continue, and they will get ever more frequent with each of you. But some of the ideas that have been thrown up that you've probably heard about in the past and you should probably get used to hearing about is greater number of residency slots, increased funding for loan forgiveness, tax credits for preceptors, which I know both of our chairs of this committee has filed legislation in the past addressing that, initiatives to address physician, and I won't just say physician burnout, I hope other practitioners will allow me to speak on their behalf that it's burnout for all healthcare practitioners. And then, as I mentioned, liability reforms. What kind of difference can this make? There's multitude of reasons and benefits we can get from increasing physicians in the state of Kentucky, but clearly better health outcomes and a healthy population. Physicians save lives. It was an honor to hear from the doctor earlier. You're talking about somebody who's truly on the front lines trying to save lives. And that's what physicians do every day, pre-COVID, post-COVID, post the next pandemic, heaven forbid. But they also help reduce costs, and they help maintain a strong and vibrant community. But there's also an economic impact to physician and physician practices. Beyond their role in safeguarding the health of our communities, physicians in Kentucky are a major driver of the state economy, spurring economic growth and creating jobs across all industries. Kentucky physicians, they hire locally, they buy locally, and they support the local economy. And through the creation of jobs with strong wages and benefits paid to workers across the state, physicians empower a high-quality, sustainable workforce that generates state and local tax revenue for community investments. Physicians' economic output, or the value of the goods and services that they provide, helps other businesses grow through their own purchasing and through the purchasing of their employees. It's quite simple. We need physicians to staff clinics and hospitals and offices. And we know where there are hospitals and other health facilities, there are jobs, greater economic development, and a healthier workforce. The AMA study, a recent one, confirms the economic value of physicians and their practices. According to the AMA's 2018 Economic Impact Study of physicians and their practices, physicians support over 94,000 direct and indirect jobs in Kentucky. That same study states that physicians generate over $15 billion in economic activity for our state, with over $8 billion in direct economic activity and over $7 billion in total wages and benefits. What does this mean for state and local tax revenue? Kentucky physicians generate $557 million in total state and local tax revenue. So clearly, there is a true and significant return on investment, health-wise and economically, when we attract and retain physicians to the Commonwealth. During the special session and through today's hearing, KMA is very encouraged that many legislators recognize this as an issue and have urged action. And the association stands ready with you, members of the Kentucky General Assembly, now and through the 2022 legislative session and beyond, if necessary, to address this vexing issue, again, with long-term policy solutions. again, thank you to the chairs and the committee.
Thank you very much. I think at this point I'm going to invite, we have Dr. Jacqueline Bitterman and Donna Meter with the Kentucky, the Kentucky Nurses Association, Donna Meter. Do you want to try to tag team it a little bit with the KMA and talk about the shortage from the nursing perspective, Nurses Association?
Certainly. Can you all hear me okay? Okay, I'm assuming that you can hear me.
Yes, we can.
Okay, thank you. Good afternoon. I'm Donna Metter. I'm the president of the Kentucky Nurses Association, and I've been a registered nurse in Kentucky for 39 years. KNA represents and speaks for the 90,000 nurses in Kentucky in all levels of nursing and practice, and nurses represent, a reminder, 53% of all healthcare workers nationally. I come to you today representing the KNA because we are, as most of you are, very concerned about staffing shortages and the overall health and well-being of our nursing workforce. And as has been said before, this is not a new nursing shortage. We have been in a nursing shortage before the pandemic. So this is sort of an acute on chronic kind of a situation. We're already in a nursing workforce shortage, and this has extremely exacerbated the problem. So pre-pandemic, some findings from Georgetown University were that 23% of nurses 55 and older plan to either leave nursing or reduce their volume of clinical work, and that the nursing workforce will be facing a shortfall of roughly 200,000 nurses by 2020. A Kentucky example that was pre-pandemic was one of our large health systems that said, typically we're hiring upwards of 500 nurses each year, the majority being new graduates, but we could probably use another 100 or 200 each year because of growth and turnover. In the 2012 through 2024 Kentucky Occupational Outlook document projects that the state will need an additional 16,047 nurses by 2024, representing a 36% increase over estimates for 2014. And an aging population at that time was cited as one reason for that high demand. So that was pre-COVID. Our current shortage data, which you've heard some of already, as you know, nearly 650,000 Kentuckians have tested positive for COVID. The vast majority of COVID patients that are pushing hospitals past the brink are unvaccinated. Available data shows that 1.1% of COVID hospitalizations are people who are fully vaccinated, so a very, very small percent. So we know that we're facing a dangerous capacity levels at our hospitals. You've heard that from Nancy. Nearly 70% of our Kentucky hospitals currently face critical staff shortages. And all this has a direct impact on the largest segment of healthcare workers, nurses. According to WOWK in northeastern Kentucky, western West Virginia, and southern Ohio, on September 19th, the fourth wave of COVID-19 is exacerbating the ongoing crisis for the nursing workforce and has led to burnout for many nurses. As a result, many are quitting their jobs in substantial numbers all across the country, with 62% of hospitals reporting a nurse vacancy rate higher than 7.5%. And that's according to a 2021 NSI Nursing Solutions report. But the pandemic has also worsened problems that have long existed within the nursing profession, in particular, widespread stress and burnout, health and safety issues, depression and work-related post-traumatic stress disorder, and even an increased risk of suicide over the regular general population. In addition, nurses need to contend with growing workloads and inadequate staffing, or not having the right number of nurses on the right units to ensure that patients receive safe, quality care. Mandatory overtime is another challenge and occurs when nurses must work extra hours beyond their shift because of staffing shortages. All of these issues can lead to low job satisfaction among nurses and are likely to contribute to nurses leaving the profession, a trend that began well before the current pandemic struck. According to my colleague at the Kentucky Hospital Association, Deb Campbell, nurses make up the largest shortage among healthcare professionals. Many have retired, some have left the bedside because of the pandemic. From a recent KHA survey, just under 5,000 open clinical positions exist in Kentucky, and about 2/3 of those are nurses. And so across the state, retired nurses are being asked to return to the profession, which is actually, there are some innovative strategies involving that. Nurses are leaving Kentucky to pursue travel nursing in other states where they can make $150 to $200 an hour, along with hefty bonuses. So they can make 5 to 6 digit salaries over a time frame of about 13 weeks. What's happening in Kentucky mirrors this national emergency. On September 1st, the American Nurses Association contacted the Department of Health and Human Services, encouraging immediate and robust action to address the unsustainable nursing shortage facing the country. According to a survey from Trusted Health, the COVID-19 pandemic has caused 39% of nurses aged 20 to 39 to report that their commitment to nursing has decreased. According to the U.S. Bureau of Labor Statistics, more than 1 million nurses are projected to retire by 2022. The long-term effects of this nursing shortage include increased patient mortality, nurse burnout, insufficient staff for hospitals and all healthcare organizations. So our parent organization, the American Nurses Association, recommends some positive steps, addressing the fatigue and mental well-being of nurses, developing strategies to retain the current workforce, addressing barriers to practice faced by nurses, addressing the persistent barriers that limit the number of qualified nursing students that can be educated each year. A little closer to home, our Kentucky nurse leaders recommend, as mentioned by previous speakers, funding to hospitals and long-term care organizations to retain, retrain, and recruit nurses. Loan forgiveness programs. We believe that this would possibly decrease the number of nurses who are leaving the state to take these large salary travel nursing positions if they could have their loans forgiven and move on. The Kentucky Nurses Association, along with other nursing professional organizations, such as the Kentucky Organization of Nurse Leaders, we will continue to provide programs to enhance mental health and resiliency, which we've been doing since basically the beginning of the pandemic, identify and promote innovative care models to maximize nursing and other healthcare professionals that are still in the workforce and still provide safe, high-level quality patient care. And then there are some other innovative programs which we are promoting, such as a nurse emeritus program, where maybe you bring back nurses from retirement at a shorter shift and more inclined to what their specialty was to assist the nurses that are on the floor. Better use and more use of nurse externs, and these are nursing students in their final segment of education prior to graduating and taking the state boards. Some blended staffing models, which are kind of an enhanced version of the old team nursing we did back in the 1970s, where you're able to spread your care among a larger number of patients with a registered nurse, possibly LPN, some other additional healthcare workers. There are also hospital at home programs that some of our hospitals are doing to better utilize the beds. Customized training for nurses who have been asked to move to a different department where they maybe have never worked or have not worked in a long time. And then at KNA, we are also very active in providing testing and vaccination clinics free through a grant that we have received. So we have actually tested and vaccinated hundreds of patients, if not thousands, particularly in the Louisville area, but we've assisted with that throughout the state. KNA also will be surveying the 90,000 nurses in Kentucky to get more information about why they may be leaving the profession or thinking about leaving the profession, where the pain points really are, and what they need. Late in 2020, you guys may not know, but in 2020, the World Health Organization designated that as the Year of the Nurse. It was actually the 200th anniversary of Florence Nightingale's birthday. In late 2020, they extended that through 2021. So it is still the Year of the Nurse. We need to keep recognizing the nurses as the heroes that they are, and the other healthcare workers that are out there as the heroes that they are, because it is the patients who suffer when there aren't enough, especially when there aren't enough nurses. So, thank you.
Well, thank you very much. That was a very great detailed report and presentation. I really appreciate the work that is being done on behalf of nurses by the Kentucky Nurses Association. So thank you for planting those great seeds and great thoughts. We really need to work together, and I know that the Hospital Association has put together a healthcare workforce work group and are partnering with many of the folks here today. So I just want everyone to know that that is going on. This is something, certainly we have a short-term problem right now. We absolutely have a long-term problem, and we need to really hone in on some of these points that have been discussed today. And I'm very glad to have folks from KCTCS here today. Certainly KCTCS, excuse me, I can say this, is a great partner across Kentucky, we have many nursing schools and other programs that train our healthcare workers, nurses, respiratory therapists, and so forth. So I don't want to lead people to believe that KCTCS is the only provider of this education, but we really appreciate all that you're doing. And I wanted you here today because I know that there are some great partnerships. In fact, I was at Gateway up in Northern Kentucky yesterday, and we talked a great deal about this healthcare worker shortage and some of the innovative programs that they're putting together. So I wanted you here to talk about how we move forward out of this dilemma, this problem that we have, and what are some of the programs that you're working on?
Thank you so much, Representative Moser, for the opportunity. We appreciate your support, and Dr. Figueroa was very happy to have you at the college yesterday. So just as a reminder, KCTCS is statewide. We're the largest of your public institutions with 16 colleges, 70 locations, and we serve people across the world, particularly some of our military students who move on from Fort Campbell or from Fort Knox. We are your community college system. Based on our legislative mandate through KRS 164, our mission is to improve the quality of life and employability of Kentuckians. We offer 115 different technical programs outside of our direct transfer programs. 95% of those 115 are technical, and we are an open access institution. So you can come to us if you need a GED, if you're a dual credit student, if you want a credential, if you're looking for continuing education for later in your career. Perhaps you're an insurance agent or someone else who needs to keep moving forward. We have a different student population than your public universities. Our students tend to be more first generation, meaning they have no one at home to perhaps help them through the idiosyncrasies of getting into college. They tend to be less prepared for college. They're older, they have children, and they earn less money or come from less resourced households. KCTCS's 16 colleges do award 98% of all short-term certificates in Kentucky, and those include many that impact healthcare, such as our state-registered nurse aid preparation courses and our phlebotomists and other positions like that, which is a stepstone into the healthcare profession. We also award 66% of Kentucky's nursing and other health program credentials. What is a credential? We want to take just a minute and let you all know that we offer stackable credentials. So somebody can come in and get that, say, nurse aid certificate, for example. They can go and work, but then they can come back and they can move towards a diploma or towards an associate degree or perhaps all three. So most of our associate degree programs do have certificates that allow the individual to go right to work and then keep working while they are moving through they're continuing their education. We use a lot of ways to bring students in. We recruit students via social media through our web presence and targeted searches. If you search in Google, for example, you may pull up a college as your first opportunity. We invite students into new careers through a number of ways. This particular website is an example of a targeted outreach program that is focused on displaced workers. So a person who is thinking about a career change or expanding their current career, coming back to work, they can go to this website and click through by career field and then get down to the colleges that offer that particular opportunity. We also do multiple outreach events at high schools, at places of business, and through special events such as Owensboro Community and Technical College's Experience Nursing Day, where they open their program on the weekend and people can come in and spend a couple of hours understanding what being a nurse means, what the educational path is, the salary, the opportunities, and maybe explore the simulators and some of the other teaching equipment. The other way that we help bring in individuals is to think about their financial need. 76% of our students receive some type of financial aid, and 68 of our technical programs, including obviously our healthcare programs, fall under the 5 work-ready scholarship sectors. And as you can see, healthcare is taking the lead in terms of the number of participants. And we are grateful to the legislature for your continuing support of these scholarships. Separately, we also partner with employers. We support companies investing in their workforce by offsetting the cost of KCTCS training by up to 75% through legislatively directed funds that go through our budget, and we call them TRAINS funding. A great example of this is at Ashland Community and Technical College, where many smaller long-term care facilities get together and put their employees in training, and then that training is offset by 75%, so the employers do not have to pay as much. We offer a number of medical associate degrees or healthcare associate degrees, and information on that is in some materials we brought to you today, printed materials. We also provided them digitally. And the information includes the information on those degrees, our diplomas and certificates, including the number of graduates for the last 3 years and their wages. Last year, in 2020-2021, KCTCS awarded 8,598 healthcare credentials to 6,886 graduates. And we know that in general, at least 70% of our graduates stay in Kentucky and are employed by Kentucky companies. Many live in Kentucky, but maybe go across the state border to work in a nearby location or a nearby city. A recent Council on Post-Secondary Education Return on Higher Education Investment report notes that across all fields, for the high school graduating class of 2011, they earned more money when they had some higher education, a certificate, diploma, or associate's degree, than did that high school student 8 years later. Since KCTCS tuition is around half that of our universities, they were also in the workplace faster with our certificates and degrees and at less cost. We were really excited to be looking forward to the opportunity to partnership with the Kentucky Hospital Association. We also are a supporter of the Kentucky Chamber Workforce Center's Talent Pipeline Management Program, which pulls together employers to look at specific job needs across a variety of employers in a region and then attempts to work with educational partners to meet those needs. Currently, there are 8 TPM healthcare collaboratives involving 49 employers across the state. They're evaluating 61 positions critical to their industry and to their success, with over 12,000 projected openings statewide. Through those collaboratives, the Kentucky Chamber Workforce Center has seen some specific barriers in these pipelines. That can include childcare issues, food insecurity, low wages in some positions, internet access, and more. And we certainly see those barriers as well for our students. But for our colleges and our students, we have other barriers as well. You've heard about the high cost of nurses to the healthcare facilities, but we are also competing for those nurses when they are the faculty in our nursing program. And the same goes for many of the other healthcare opportunities. We compete with, there are many providers. It takes all of us to meet Kentucky's needs, but we're also all competing for clinical sites and wanting to ensure our students those appropriate offerings. We have lower applicant pool numbers for some programs or in some locations. For example, in our nursing program, we have a great number of applicants for BCTC, a large city, lots of people, but maybe not enough at Madisonville, smaller city, more rural. We also have some student concerns around algebra and some other course requisites that we are looking at, but many of our courses do transfer to universities, and we want to also meet the needs of our university partners. We have some terrific programs at our colleges to engage healthcare workers into apprenticeships and also into pathways. We have several nursing pathways, for example, dual credit courses that lead directly to a nursing program, a paramedic to registered nurse pathway, a nurse aide to licensed practical nurse to registered nurse pathway. And then all of our 2-year nurses, because they are at 2 years, our graduates take the same exam that makes them a registered nurse that a 4-year graduate might take. Those individuals who have graduated with their ADN degree, their associate in nursing, they also can take 2 years of classes on top of that, layer on top of their degree, and get to their bachelor's degree again while they're working. So I'm going to ask Dr. Bitterman to speak to a couple or at least one of JCTC's innovative nursing programs, particularly their apprenticeship program.
Thank you. Thank you for the opportunity. Can everybody hear me?
Yes.
Okay. So we were approached by one of our long-term care facilities to be able to increase their pipeline of nurses. And so we have started an LPN apprenticeship at the Carrollton campus, where someone will go from a nurse aide to a licensed practical nurse in 1 year with a flexible schedule. And so to meet the needs of our healthcare partners, we have done our lectures online. So all of their lectures are provided asynchronously when they are available and not working. And the only time that we require them to come to campus is for lab and clinical. And we did this to increase flexibility, and it has been wonderful over the pandemic to allow our students to still contribute in the nursing profession while continuing their education. Another opportunity that's happened at Jefferson that we're really proud of as well is we've opened an evening hybrid option for the registered nurse program at Shelby County campus. This was financially supported by 4 of our healthcare partners and matched by the Governor Reserve Fund to allow that to happen. This is an evening program. Again, our lectures are online. Students can watch them when they are available. We provide one-on-one tutoring services as needed, and then they come to class for lecture and clinical. And this really has contributed to the workforce needs of our region and allowed our students to have flexibility in what they need to complete their degrees.
Dr. Bitterman, do you want to speak to the Trilogy Apprenticeship?
Yes, so that is the one in Carrollton that I mentioned. Trilogy Healthcare is the one that partnered with us to do that. And so their students work no more than 25 hours a week and then come to our campus for lab and clinical to complete that. And they do get credit towards their skills that they complete while they're at work. So we do allow some test out of different types of skills that they can demonstrate while they're working.
Thank you very much.
Thank you.
KCTCS is supported primarily in 2 ways, through student tuition and through our state funding. As you and others in the legislature consider your budgets, like everyone else, we're hopeful that there would be support to help us meet some of these needs. KCTCS receives many fewer dollars per student than any of the universities. And yet our 16 colleges are providing that skilled workforce that you all are calling for today, and our students are getting in that workforce much more quickly. We've listed a few of our funding priorities on this slide, and you also hopefully received the handout that's our Competitive Workforce Investment Initiative, and we're asking that you consider that as a way to help all 16 colleges meet needs across the Commonwealth. We really appreciate the opportunity today, and like the other presenters, would welcome any questions. Thank you, Representative Moser.
Thank you so much for being here. I just find it fascinating listening to you, and I'm just always impressed by all of these groups. But KCTCS has really come to the table with some innovative and creative programs. I love the common sense approach to creating those career pathways and working with other universities and certainly our providers. So obviously we have all of the right people at the table to discuss this issue. We've got a long list of things that we can work on, and certainly I would encourage all of my colleagues here to visit their local community colleges and really take a tour, see what they're all about, and see how we can support them, because I came away with some ideas yesterday, and we'll continue working on those. We do have a couple of questions. I know that Co-Chair Alvarado would like to say something first.
Thank you, Madam Chair, and thank you to the KNA, KMA, KCTCS for coming today. This is great. There's a lot of members that we have on this committee and in the General Assembly that have probably less than 4 years of experience. And this has been a topic that, like we said, has been out there for a long time. I'm going to throw something out that maybe the members would want to write down, because I've mentioned it before when I've filed other bills. It's a Deloitte study that was done here in the state of Kentucky. It's entitled The Commonwealth of Kentucky Healthcare Workforce Capacity Report. It came out in May 2013. It's an 85-page report. It looks back in 2013 with the number of physicians, nurses aides, you can go through it. It's an entire report on this. And then recommendations, because people are saying, well, we should put together a workforce to figure out what we got to do to help retain workforce. That work has already been done in this state. And I don't know that anything in that report has been adopted. I filed several of those bills. I know my co-chair has filed several of those bills of things in that report to get done. We got one passed, only to have our Supreme Court throw it out the window and say it was unconstitutional. So there's other methods of getting some of those things done, but I would encourage the members to review that report because it's been out there at least for 8 years. It'll be 9 years when the next session comes into place. And if we just adopted, I think, the majority or most of those things, we would probably improve our situation here in our state because this has been a long time coming. And really, COVID has just been the straw that's broken the camel's back. I remind everybody that we talk about having people want to claim that there's a right to health care. Again, you can have all the tubes, hospital beds, pills, whatever you think constitutes health care. Healthcare is ultimately people providing a service to other people. And if you don't have those people that know how to deliver those treatments and those medications, you don't have healthcare. And our nurses in particular, our doctors are the lifeblood of our healthcare system, and we're hemorrhaging. And like I said on the flu of the day, all bleeding eventually stops. It's a statement that we say in healthcare. Either the patient passes away or you manage to stop the bleeding. We're in a critical situation. We're pretty anemic. We've got to do something to help with this. So I appreciate all of your thoughts. I'd encourage members to review that capacity report. Thank you, Madam Chair.
Thank you. Maybe we can share that with everyone. Representative Prunty.
Thank you, Madam Chair. I'd be remiss if I didn't give a shout out to Madisonville Community College and Dr. Cindy Kelly and all the fine work they do there. I know they have a PTA program, a nursing program, and I work very closely with them. So thank you all for your being here. My questions are for Corey. And you may not be able to answer this question. My husband's in a physician, and he's currently on the faculty of the U of L's Owensboro Health Family Medicine residency program, trying to get more family practice. But personally, I've seen issues with medical education. I mean, it seems like, and I could be wrong, and others could correct me, but it seems like some of the, and maybe a cultural thing, but sometimes it seems like the younger ones coming out, they don't want 9 to 5, don't want to see in the hospital, don't want to see after hours. Is there any way that medical education, what's going on with medical education? Where did hospitalists come from? My husband was one that he was a family physician. He wanted to see you if you were in the office, in the hospital. It's like, where's that going? And then the other thing, like he told me once, if some of the new ones see 6 or 8, they think they've worked hard. And I said, are they that lazy? He said, it's the EMR. So how much is medical education and the electronic medical record? Can you speak to that?
Well, I certainly don't have any empirical data to back this up, but I do talk to a lot of doctors. We have 5,000 to 6,000 members across the state, and so I have a lot of conversations. So I'm speaking anecdotally, and I do think there is an element of that is there's cultural changes. Physicians, nurses, and other healthcare practitioners have, many of them have made a decision that I want more stable work hours. I want to spend more time with family. And that's all legitimate. But I do think that we're seeing that. I do think that the real burden, and I didn't get into a lot of details about it, is really about the administrative burden, the EHR, the prior authorization. These rules that have been put in place that may have been very well intended, but are not getting the kinks worked out now after many, many years. And so I think that we've tried to pass some legislation. We passed some prior authorization legislation, Dr. Alvarado and Representative Mosier. I think many of you on this committee were very influential in that. I think we have to continue to identify those administrative barriers to help streamline the provision of health care. I heard a doctor tell me once, and I've never forgotten it when he told me this. He says, I miss when the practice of medicine was a profession and not a job. And that has always stuck with me because what he was referring to is, and we know healthcare is a business, but a lot of the business aspects, not being able to streamline that and make it more efficient. And many of these things were meant to be more efficient, right? EHRs, electronic health records, were meant to be efficient. But as the federal and state government get more involved in the provision of healthcare, there's more rules. There's more dollars involved. That means that there's more rules, more strings attached. Well, that also means administrative burden, and we've got to get very serious about streamlining that out so that they don't get burned out. They want it goes back to being a profession and not a job. I'm sorry I don't have data to back that up, but I think coming from the the mouths of physicians themselves carry a lot of weight with us.
Thank you. And Senator, you talked about, when I looked at you yesterday when they were talking about prior authorizations, and I'm going to email my federal reps about the GME slots and whatever we can do there. And I'm willing to stand with this committee to do whatever work we need to do to help. So thank you all.
Thank you. Representative Bowling.
Thank you, Madam Chair. And I appreciate each of you coming and testifying today. A lot of good information you've shared with us. I'm going to talk about a situation that happened in my Southeast KCTCS last year. As they were having conversations with hospitals and providers, there was obviously, it was iterated, there was a need for more nurses. And so they started planning for that in November, and they submitted for an increase of 15 nurses, which has to go before the Board of Nursing and get approved. They got denied on January 2nd to increase their nurses in their program by 15. They appealed it. They were denied again in February, and we've not been able to do so basically because the Board of Nursing has said no. They cited two issues in their original reason they denied it, I guess, and Southeast gave them the information, said, y'all should not deny this. Our retention rates are over 60%. I think that was one of the major issues. Are y'all seeing that? Was that a one-off instance from the Board of Nursing, or are y'all seeing that across the board as we try to make sure we have good nurses, getting the training they need to address this problem? If the Board of Nursing is just going to say no from an increase on education, what else can we do?
We have had colleges that were approved for increases and others besides Southeast that have been denied. We have been working with our nurse leaders and with the Kentucky Board of Nursing to help the Education Committee, which is the committee that recommends to the full board, about increasing caps, ways that perhaps they can better understand the difference between associate degree nurses and bachelor degree nurses, because we sometimes feel like we're held to some standards that are should be different for the population that we're bringing. Our nurses still pass the same exam, and they must pass that exam to go ahead and move into the workforce. So we would welcome the opportunity to work with the Kentucky Board of Nursing to consider caps. We certainly see the need to have the appropriate resources to teach and have a good experience for our students. We certainly understand that we have another group keeping watch on our programs through our national accrediting agencies that help us define, again, quality. But we would welcome working with the Kentucky Board of Nurses to look at how to more quickly increase cap numbers.
Great, thank you very much. And would there be any way to get the information on, I guess, the number of slots that you all have requested over the past, 2 years, 18 months, 12 months, whatever it may be, and then the ones that were approved and the number that's been denied? That'd be really good information to have.
I can definitely collect that information for you.
Okay, thank
We'll
you.
be happy to submit that afterwards.
Thank you. Thank you, Madam Chair.
Okay, thank you. And Representative Bray, do you have a question?
Yes, thank you, Chairwoman. Thank you all for your robust presentation. I've got a question on the workforce portion of it. As legislators, we've been hearing about statewide shortages in teachers, police, fire, EMS, paramedics, social workers, and even from, manufacturers. Do we have any data showing where our college graduates are going? Where from, like through the KCTS, I guess where, once they leave, what sector they're going into?
Yes, sir. We are able to provide follow-up information on our various students. We were able to provide a little bit in terms of our graduates, and then, the number we graduated and where they're going that we gave you today. But we are able to do that. A lot of it is done in partnership with Kentucky Stats, and so they tend to be our primary provider of some of that data. We follow up based on employment out 3 years. After our student leaves us. So if you have a specific area or perhaps the top 5 sectors, I'm not sure how much you want to go into detail on those different kinds of jobs.
Okay, yeah, if you could just give me, like, let's say the top 5 sectors, because I know historically healthcare, it has been a huge one, and to see the shortages that you all are going through right now, that would kind of be helpful just to see what we're kind of transitioning to. Have you all seen changes in graduation rates or enrollment rates?
Our enrollment numbers have been falling over the past 3 years. That's a national trend with community colleges. We do know that our university partners aren't necessarily seeing the same thing, so some of it may be, well, I guess it's twofold. I showed earlier that our students tend to be older, which means they tend to work or have childcare issues, and we feel like, especially over the last 2 years, the childcare issues and the uncertainty about virtual school versus in-person school, I think, has impacted some of our enrollments. Our university students tend to be younger, and they're off to university, right? They go for that full university experience. So we are seeing enrollment decreases. That said, our students who we do bring in, we tend to be retaining more, and we are graduating more. So we are able to support the ones that come, but we are struggling with getting individuals to us. Some of it, I think, is they're right now going directly into employment as well. The wages are pretty high because there are shortages, and so individuals may be choosing to go to work before they go to school, and then we hope that we can grab them as they get to work and start them down a path, because we know that some higher education, a certificate, a diploma, or a degree, will provide them more stability and more economic success across their work life.
Okay, thank you all. Really appreciative of what you all do. Thank you.
Thank you.
Thank you.
Thank you. And the last question, Senator Meredith.
Thank you, Madam Chair. And first, I want to commend everyone who's made testimony today, and also that you're working together on this issue, because it does affect all of us. And I want to echo Corey's sentiments earlier. Regardless of what comes out of this task force and recommendations, whatever we adopt, if we haven't improved the quality of the work life, we really haven't accomplished anything. And we know we spend double what other industrialized nations does on the administration of healthcare. So I would encourage you folks to also work collaboratively to challenge this, to really look at each and every regulation that's affecting healthcare and see if it really brings value to the system. I think there's a lot that doesn't. And value to me is it either increases the quality of care or improves efficiencies, or both. And I think that's one of the things lacking in electronic medical record. In theory, it's a great idea. Practical application, it's not. And I was one of the earliest proponents of rural hospitals to do this, and I've admitted it's a mistake because there wasn't a good system out there. It's decreased productivity 25-30%, and truly, I don't think at this point has improved the quality of care. So we need to be encouraged enough to step away from those things, but we really need to be aggressive on this, and appreciate the report that Dr. Alvarado referenced, but I'm sure since 2013, a lot of things have been added that have added to this problem as well. So we need to be aggressive with this, but thank you. Thank you, Madam Chair.
Thank you. And I absolutely agree with all the points that you've made. And I think that we've had a really good discussion here today. So I appreciate everyone being here. I think, on one last note before we leave is we don't just have a healthcare worker shortage, we also have an increased demand. And we've seen that certainly through COVID, but we also have, an increased demand because of our mental health needs, our addiction issue, and our poor health metrics, our chronic disease state. So I think that, while we work on all of this, and this is absolutely a priority, that we don't forget that we are driving the demand for those healthcare workers because of all these other issues. So thank you so much for being here. Thank you for your work, and I look forward to working with all of you.
Thank you so much.
Thank you. Next, we have a report and update on the public health transformation, and I believe that Commissioner Stack has been very patiently waiting to give us an update, and we also have Jan Chamness with the Department of Public Health as well. So, and maybe Sarah Best is with us from the local health departments. So if you are on, if you could just introduce yourselves for the record and go ahead with your presentation. Thank you so much. Thanks for your patience.
Thank you, Representative Moser. So I'm here to support the importance of public health transformation This was a topic that is desperately needed, and where the legislature worked very collaboratively last year and leading up to last year with the local health departments across parties, across multiple different constituencies to bring about needed reform. Jan Chamness and Sarah Jo Best will introduce themselves as they do their presentation, but Jan is the Director of Public Health Transformation at the Kentucky Department for Public Health, in addition to having been our division leader for women's health. And of course, Sarah Jo Best is the Lincoln Trail District Health Department Director, and also the President of the Kentucky Health Departments Association. They are going to give presentations to you, and then I'm going to be available with them for Q&A. So thank you for the opportunity to be here. And Jan, I'll hand it to you.
Thank you. All right. And can everyone see the screen? Just a thumbs up from somebody.
Yes, we can.
All right, great, thanks. Thank you again. Thank you for this opportunity to allow me to come and talk about public health transformation and the progress since the passage of House Bill 129. I wanted to just briefly go back to the overall purpose of public health transformation. As you all have seen before, this was the map that was introduced in 2018, and it represents the pension crisis across the state, where the employer pension contribution rose exponentially and forced local health departments to either react through layoffs and elimination of programs or risk closing their doors. Some other things happened prior to this, the pension crisis, which also impacted local health departments, like federal and state policies, the Affordable Care Act, and Kentucky's Medicaid expansion. Good policies, but diverted programs that were once provided in local health departments to either a medical home or a primary care provider. Another reason to move toward transformation is this national model, which you're seeing two models, one on the left, which is was introduced by the Institute of Medicine, the one on the right by the Department for Health and Human Services and the CDC, but both models really were a call to action to public health across the country to address social, environmental, and economic conditions that impact our health. But really, the main reason to transform Kentucky's public health system is because what we're doing now is just not working. This is the latest report from the County Health Rankings, or America's Health Rankings, that show Kentucky's health behaviors as 48th and health outcomes as 46th. So simply put, what we're doing is just not working. We're not getting any healthier as a state or as individuals. And public health transformation is really our call to action to work together to create this more efficient and sustainable public health system focused on improving and producing better health outcomes for Kentuckians. And House Bill 129 is helping us do just that. House Bill 129 led to amendments in the statutes, which basically introduced this categorization of public health programs into core public health, which included foundational public health, those programs which typically are legislatively mandated, as well as some other programs in public health like WIC and HANDS, and those programs related to harm reduction and substance use disorder. And then all of the other programs were put in this category that we call local public health priorities. And that category really gave local health departments some flexibility and some option to choose other programs in addition to assuring that core public health services were met, additional services that were needed as a result of their specific community needs. Another amendment to the statute as a result of House Bill 129 to help us further understand the local public health priorities was this introduction of these key terms used as criteria or guidance to local health departments, as well as the state health department and program staff to better understand how to select these public health priorities and the process to provide these public health priorities in their communities. And we are still working with public health transformation efforts to further define these key terms so that as a state department for public health and local health departments, we're providing some consistency across the state and rolling this out. One of the first things that we needed to do was really, it's easy to say that anything that wasn't core was pushed into local public health priorities, but we really needed to specify what those programs were. And so the work over the last year has done just that. Groups have come together, combining both state health department staff and leadership, as well as local health department staff and leadership, to identify more specifically what these programs are. And I just want to emphasize here that these programs are no less important than those within the core public health programs. It's just that these are programs that now, once local health departments consistently provide those core public health programs, then they can pick and choose and choose to focus more on the selection of these programs based on their local needs assessment within their specific communities. I just wanted to give you an overview of the process that's been going on since the passage of House Bill 129. We've been moving on a fairly good pace over the past year. House Bill 129 was the focus during 2019. And then in October of last year, we relaunched a fairly substantial planning effort focused on public health transformation, obtaining buy-in that this initiative was not a directive at the local health departments, but rather a collaborative effort of state and local public health to really improve public health and redefine public health and moving forward. It has led to a number of work groups and work plans. It has led to the iteration of a new strategic plan using public health transformation as a key tool in overseeing the strategic planning efforts. We have focused on health equity and in looking through this lens of health equity in all of our programs. And we've had some fairly robust leadership and staff development through this process. And as we move forward, we will see that we now have a very updated strategic plan along with this public health transformation, creating this culture of change to move forward and really focus on changing public health and redefining public health. This is just a simplified structure to really show you how comprehensive our efforts have been over the past year. This is not intended to be any type of hierarchical organizational chart, but rather just a way that we manage the process and moving forward. And we'll see this process continue as we roll out the implementation plan into the future, beginning with this month and going into next year, and the next several years. So I just wanted to share that this is a very complex and comprehensive process that we've been through. I want to add that during this process, there were over 100 people representing both local health departments and the state health department and some of our sister agencies on a lot of these work groups. I wanted to point out the strategic map, and I know that it's hard to see on the slide, and I believe you have a copy of it in your packet, but you'll note that this strategic map was actually adopted in 2012, and so it really hasn't changed a whole lot. The strategic priorities continue to be people, quality, efficiency, and effectiveness, and building public health capacity, all leading to our focus on our mission to improve the health and safety of people in Kentucky through prevention, promotion, and protection. We did tweak it a little bit to really infuse this overarching principle of promoting health equity in all we do. But I just wanted to emphasize that our strategic planning efforts are not new. We've had a rich history of strategic planning for quite some time. Just to give you a little progress to date, I won't focus a whole lot on these because I've mentioned some of them already, but I think it's important to just point out that we have introduced some enhanced communication tools to just focus and emphasize the importance of accountability and transparency through this process. We have a designated public health transformation team with a focus on performance management and accountability. And we've really worked on enhancing our partnerships with some of our external partners like the Kentucky Primary Care Association and some of their FQHC members, as well as university and hospital-based primary care clinics. And I think that we really are starting to see public health transformation as a movement that's going throughout public health in Kentucky to create this culture of change. So with that, I will turn it over to Sarah Jo to give her presentation.
Can you see my presentation come up? I know I need to start it from here and make it bigger, but can you see that?
Yes, we can see it. Thank you.
Okay, thank you. As Jan mentioned, my name is Sarah Jo Best. I'm the president of the Kentucky Health Departments Association and the public health director here at Lincoln Trail District Health Department. And I'm going to talk to you a little bit about what this means for the local health department, how we've been impacted from it, and some successes, really. I will focus a lot on the successes that you guys have performed, and I want to thank you for your work on this. So as the president of the Kentucky Health Departments Association, I represent 60 of 61 local health departments across Kentucky, and our executive director is Dana Nichols. As Jan mentioned, public health transformation was born out of necessity. Many local health departments faced financial instability. We simply couldn't be everything for everyone. And we often quoted ourselves as being a mile wide and an inch deep. Transformation really provided a narrowing of that focus, a minimum package of services that was available to all Kentuckians, regardless of where you lived. And it prioritized our services to make sure that we were meeting basic public health needs as we evaluated those programs. This is the stool analogy that was used a lot during that time when we were working on public health transformation. And I'll just say, as one of the CADA members a long time ago, when we were sitting around a table at a CADA meeting doing a strategic plan, we really wanted this to happen. We had that vision. I think Jan was around that table too at that time as a local health department director. And just to be where we are today and the successes that have come out of this, the collaboration that's come out of this, and really the change in culture is something that I'm incredibly proud to have been at the very beginning of, and now as we move toward implementation. The stool analogy, we use this as a three-legged stool that we needed all three legs in order to really have a foundational public health system that could be nimble enough to respond to emerging health threats and stable enough for our routine services. The three legs of the stool were focused services, so introducing that simplified and focused public health model with clearly defined priorities that prevented duplication of effort, reduced waste internally and externally, and also provided the ability to have more collective impact. So before in Kentucky, if you saw one health department, you saw one health department. Now, if you see the health department, you'll see similarities, you'll see a core package of service, and there's more consistency, thus making us more accountable to the public that we serve, and our service is more recognizable. The pension system, stabilizing that was also a big key for us on our leg of the stool. This allowed for more manageable planning and budgeting for local health departments. It provided the opportunity to add staff at normalized cost. And then the last leg of that was equitable funding. And that really created an equitable funding formula for foundational or statutorily required services to ensure that all Kentuckians have access to these regardless of their zip code. And so that's what that image looks like. In the remainder of my slides, you're going to notice that I have check marks next to actionable items or goals of the broader categories of public health transformation. The check marks represent that significant work has been put into each of these areas. But with any goal, continued objective, with any goal or objective, we need to continue our work. We'll have specific tasks associated with that. We'll continue to improve, to work on those and evaluate them. You've seen the image of the core public health package. Jan showed you that. You'll see it throughout the course of many of the presentations that we do on public health transformation. But this was so important to us as local health departments. The work that went into this really simplified, focused, and prioritized public health services. And it did so by assuring that these statutorily required services, that's where we put our resources first. It really prioritized them to be first. And I can say as a local health department director, that wasn't always the case. We may put a lot of resources over here, and we may neglect or use leftover, if you will, funding or resources to fund areas on the left. And these are really the things that have been studied and tried and true, that if we put resources here and we devote time and energy to them, we do see changes in health outcomes in our community. And so that was really important to us, that not only were they required by statute, but our statutes actually matched what a healthy public health system would look like. So it assures that resources go here first. And then it also established the core public health services, such as WIC, HANS, and harm reduction, as Jan mentioned. And that's really because those were needed. We understood that while they may not be statutorily required, our community health assessments across Kentucky were consistent enough that these three areas were needed all across Kentucky. The new thing with this too is the addition of a community health assessment here that was long overdue, and as a result of public health transformation is now included in 902 KAR 8160. And that is a really good thing. It provides accountability for programs that we may do. Jan mentioned an assessment is something that we would have to do if we want to do other optional programs. It uses data to drive decisions. And that's really important. So it uses qualitative and quantitative data. It uses community input to help drive where we're putting resources, and requires us to evaluate to make sure that we're having the intended outcomes that we want. So using data to drive decisions is now also outlined in KRS 211-187. That's also a positive impact from public health transformation. This slide really looks at stabilization of the pension system. As you know, every fall, KRS would crunch the numbers, determine how large the unfunded liability was, recommend a percentage of payroll to employers to keep the pension system viable for another year. Many public health employers responded by decreasing their payroll, thus controlling their pension costs. Many outsourced to private contractors who didn't provide or who don't provide state pensions and don't pay into KRS. There was an over 51% decrease in staff in local health departments from 2008 to 2020 in order to help control these costs. House Bill 8 froze the pension contribution rate in statute and enabled local health departments to better forecast operational costs and pension contributions for decades to come. So this also eliminated the constant uncertainty of the ever-changing ARCs, thus stabilizing the quasi-pension issue. It also provided the opportunity to bring new employees on at normalized cost, which was advantageous for us as well. So while House Bill 8 did provide for better budgeting and was financially beneficial for 33 out of 61 local health departments, there was 27 local health departments that saw their rates increase to 85% or above. And these ranged anywhere from roughly 85% to 300%. So it should be noted that there are health departments that will not be able to support the increase after the loss of half of the subsidy, even through taxation. Currently, we have 48 counties above the state average of 4.72 cents per 100 of assessed property value, 7 that do not have established public health taxing districts, 9 who have tax rates at 8% or higher, leaving very little room for growth, and 2 who are already at the maximum tax rate, which is 10 cents according to KRS 212-725. Also keep in mind that the counties with the highest tax rates are typically poorer, rural counties, some of which who have declining property assessment rates due to losing populations and valuations associated with unmined minerals. So Letcher County is an example of that. Another success here in the equitable funding was the evaluation of fees associated with our environmental permits. This was also work done under public health transformation. Amendments were made to KRS 211-180 to allow for improved alignment of fees with actual cost of providing those services, which reduced the amount of public health tax dollars used to support private business permits. Public health transformation, as I mentioned before, did identify an equitable funding formula, and that's the work that CADA has put on the priority for this year, is really assuring that that equitable funding formula occurs. So it basically looks at the cost of providing foundational services, which are those services that are required by statute. It wasn't intended to include the cost for any of the other programs, to include core community identified services. Most of our core services are funded by specific grants. The calculation is based on the absolute minimum number of employees needed to conduct those statutorily required services based on the population size of the service area. And it's directly linked to things like the cost of salary, benefits, and operations. It also depends on the evaluation of the actual retirement costs for foundational employees. After that cost is determined, it requires that the minimum public health tax be dedicated to those foundational services. It requires that the 90% of the fees retained by local health departments for the environmental permitting and inspections be subtracted from that cost. And it also subtracts out federal preparedness dollars received by local health departments. The remaining expense is what should be included as an individual budget allocation within the state budget to each local health department in accordance with KRS 211-186. Without this funding, these services become unfunded mandates. And as the health departments need to further streamline services, lack of this funding may lead to the inability to provide core or foundational services. I've included an example for FY 2022. We are working on this to get numbers for fiscal year 23. Our estimations at this point are $7.7 to $9 million, but we will have those very shortly and are working on them right now. I also wanted to demonstrate with this slide the commitment from the local level in assuring those foundational services are provided. You can see in this example, 83% of the funding for the operational costs are funded locally. And I'll just end by saying that public health has long served as invisible guardians, working across all areas of life to protect and improve the health of our people and our communities. We need to assure that it's funded appropriately and that we have a strong foundational system that is nimble enough to respond when needed and is supported and valued by our communities. That concludes my presentation, and we will open it up for questions.
Thank you so much, Sarah Jo and Jan, for those great presentations. You are reminding me of what a big project this was, what a great collaborative effort this was, and I'm so proud of all the work that we were all able to do. I know that there was a lot of work that took place behind the scenes for years leading up to this legislation. So I think this is a great thing. It's very data-driven, as you said, and very common sense, and a great example of DPH transformation. Really finding efficiencies that perhaps we can take this model into other areas of state government. I'm very proud of this. So, and you're right, we need to fund this. We need to make sure that this that we complete this whole project with the funding this year. So, thank you. Do we have any questions from the committee? I don't see any. So you covered everything. Thank you so much. It's great to have this update and
Representative Mosier?
Implemented.
May I say, I may have misspoken. I may have said my numbers wrong. It's 17.7 to 19 million. I can't remember what I said now. I might have said 7 and 9.
You said 7 and 9, so I was really impressed. But
yeah, my apologies. That is wrong. It's 17.7 to 19. So my apologies.
Thank you. I wondered. Okay.
Thank you for all the work you put into this. I feel like without you, it wouldn't have happened.
Well, I thank you for saying that. We have great team members here, so thank you. All right. Well, I think we are all finished with our presentations. We do have a few block grants that we need to just review, and those are all in the packets. All members received those ahead of time, so hopefully they're aren't any questions, and those are just for review. Do you have something, Representative Fleming?
Yeah, I didn't know if so nobody's here to just discuss or review the block grants in general.
Sorry. Oh, yes, thank you. Laura Began, are you on?
I am. Good afternoon.
Good afternoon. Thank you for sticking with us. All right. Representative Fleming, do you have a question?
I do. I won't be very long. I wanted to ask Laura just a couple of questions about community-based services and such. Do you know how many past due cases do we have statewide in that regards to the, for child protective services?
I do not have those numbers on hand, but I can get those for you, the number of past due cases. We also have a quarterly caseload report pertaining to social workers for both child protective services and adult protective services that may be of interest, and I'd be happy to send you that as well.
I would appreciate it. I've been getting reports and understand that a lot of these case loads on these workers are anywhere from 80 to 100 in excess of that. And when you look at the number of past dues, it seems quite alarming that these are not being handled or worked through. And I just did some quick numbers. It looks to me, well, I know from the statutes that should be 25 or less in terms of workload. And when you look at just the average number of past due cases, at least I believe just in Louisville and Jefferson County, it's around 34. That in itself is above 25. But when you add on additional cases that are in the process, that's around 25 additional cases. So I want to bring that up to your attention. I really, really would stress that you get back to us to give me a full explanation of what's going on with these caseloads, because it's quite alarming that these children that are going through these horrible situations are not being taken care of and not being worked through.
Yes, sir. Yes, caseload size definitely has been an issue for the past few years. In Jefferson County, those numbers were around 80 caseloads per social worker. A couple of years ago, we have worked hard to get those numbers down. I believe the 35 number that you reference is the total cases, including past due, but also including cases currently being worked. That is still too high. I mean, it's down quite a bit from a couple of years ago, but yes, national experts recommend a caseload between 16 and 18 per social worker. So we still have a long way to go. There are some issues specific to Jefferson. The caseload number is different throughout regions, throughout the state. But again, I would be more than happy to provide you that information. We are statutorily required to report on that quarterly. And caseloads, right, with recruitment and retention, they're all being focused on by DCBS right now as we work to build a 21st century DCBS and really focus on, again, recruiting, retaining social workers. That's the best way to get that caseload size down. So we would love to have that conversation and follow up with you.
I appreciate it. I just want to make sure that when you said 35, I mean, I've got the average almost 60. When you look at one particular area, it's almost 60 cases, which is broken down between 34 past due and 25 that are currently active. So I need to get some clarification. I want to belabor this a little more. But if it's up to the chairs, I would like to have y'all come in. And once again, it's up to the chairs to have y'all come in and give a little more full report on what's going on. In addition to that, your plan of action, since you've mentioned that this has been going on for several years, I know this has probably been, escalated during the pandemic. And I'm afraid that the spike is going to really increase. And we're going to look at some individuals who might get an opportunity to go elsewhere to get a higher paid, that you're going to get in a worse situation. So there needs to be a sort of a plan of action in terms of addressing this much sooner rather than later. And I appreciate your work on it in the past, but I think we're at a critical point of basically falling off, and this is getting really in a horrible situation.
Thank you, Representative Fleming.
Thank you.
And thank you, Laura, for indulging us. Yes, this is an ongoing question. We've had some updates from DCBS and Commissioner Straub in the recent months, but I would like to dig down on this a little bit further. So thank you for bringing that to our attention again. Now we need to consider some regs, and these have all been reviewed. There is one regulation that we would like to, I think there's been a recommendation to defer to move 201 KAR 009290, proposed regulation having to do with athletic trainers. And I know that the KBML, they are under KBML, so they've written these regs, and there have been some public comments, and we believe that there is a need to defer this reg for further action, and I will entertain a motion to do so.
So move.
I have a motion and a second. All in favor?
Aye.
Any opposed? Are there any other questions about any of the other regs? Okay, seeing none. We will consider all of these regs reviewed, and seeing no further business to come before this committee, I will entertain a motion to adjourn.
So moved.
Thank you. One quick announcement. The next meeting of the Interim Joint Committee on Health, Welfare, and Family Services is Wednesday, October 20th at 1 p.m. Thanks very much.
Hey, how you doing? Good. How are you, Chairman? Good to see you. How are you? Take my plea again. You okay? Yeah, I see her. How are you doing? Good. Take it easy. It's a tough one. I go, yeah, I know it is for you guys. It needs to happen. Hey, yes. Well, I hope that came out. It did.